Okay, my name is Amy Lee, and I am going to be the moderator for this Ohio Public Health Academic Forum, which is being done virtually. We are recording these presentations, so in case you miss one, you would be able to see each of them, and it will be posted on our Public Health Academic Forum's EduBlog website. So please visit the website and you would be able to see these presentations. So I'm going to show you the agenda for today. We have 4 outstanding presentations, and I'm going to have the presenters individually introduce themselves. And we are going to start off with Carissa Smock and Lisa Schindler. Carissa Smock has been a longtime presenter for us, and we're going to go ahead and get the presentation switched over, and I'm going to set our timer clock. Carissa, whenever you're ready.
All right, thanks so much everyone for taking the time to listen to our conversation and our presentation today. I'm here with Dr. Lisa Schindler, who is an alum from North Central University and does very important research on COVID, among many other things, heading up many trials. I can let her speak to that a little bit more. I'm a professor at North Central University in health services, and I do research like this as well. Lisa, do you want to share a little bit?
Yeah, hi, I'm Dr. Lisa Schindler. I work for a big hospital and I do clinical research. I am a clinical research coordinator and one of the lead coordinators on COVID studies that we're doing here at the hospital. And as she said, I met Carissa as my dissertation chair, and I'm an alum of NCU, North Central University.
Yeah, thank you, Lisa, and we're fortunate to continue our research and work together.
For sure.
Yes. So, all right, everybody see the slides okay still? Okay, so just the disclosure slide that this was funded partially by North Central University. The purpose of our study is to develop a socially distanced instrument and design to determine changes in physical activity and stress levels pre, during, and post our COVID-19 pandemic. So as we are all living right now, and let me get this in slideshow. Sorry. My cursor doesn't want to work. Okay. All right. Well, I guess I'll just go from here. As we're all living the stay-at-home mandate, we know that we're only to leave home for the essentials, such as groceries, medications, but we are very much encouraged to get out and get physical activity. So what is unknown about this is if people are actually displaced from their routine physical activity, or, you know, if in fact there are more people out in the parks. We know that there are more people out in the parks, but are there more people getting physical activity? We also know that people are going out in smaller groups, and they are staying closer to home, only going about 2 miles away from their homes. We also know that the requirements or the recommendations for physical activity have not changed, and that's because there are many protective factors strengthening our immune systems to actually fight off COVID-19. And if this physical activity is done outdoors, there's additional benefits from absorption from vitamin D, and then protection against other chronic conditions that weaken the immune system. And I needed to acknowledge here the American Public Health Association Physical Activity COVID Task Force. These folks have really jumped in to put together peer-reviewed research that has been in place, that's been published, also white papers and blogs, and just gathering safe physical activity recommendations for APHA at large, but also the general public. And here I just want to go through some of those recommendations. You can see this from the World Health Organization, recommendations about how to stay active while at home. Then we have recommendations about how to stay active while working from home. And parks have been very active in creating signage, increasing patrolling, putting together very helpful guidelines in making sure that folks are safe when they do access their parks. All right, and even our partner, Cleveland Metro Parks, you can see some of their signage here. And we know that folks are actually following a lot of this, you know, going out in those smaller groups and making sure that parking lots are not full when they decide to actually visit a park and things like that. So our partner, Cleveland Metro Parks, has agreed to recruit participants through their Community Pulse, which is an online research panel of 3,000 Northeast Ohioans. So we're very excited about that. And I'll let Dr. Schindler take it over from here.
So we're going to talk about our instruments and data collection. Our participants were asked to and will be asked to download an app that will share data. They'll complete a before and during survey, and then a post survey, and then we're looking to do a follow-up interview. The participants will enter physical activity from their phones and fitness devices. And they'll also do a self-report on their activity mode and location. We also have included questions about the changes in childcare and their employment. And then we're going to create and use a code that will link the before and during to the post and the follow-up interview. And then we have additional instruments that have been tried and true. We have the International Physical Activity Questionnaire, the Rosenberg Self-Esteem Scale, which is a mood questionnaire, and the Positive and Negative Affect Schedule, which is another mood questionnaire. And then for our analysis, we will use the SPS software to calculate both the descriptive and the inferential statistics. And then we've also added Google Analytics, which will be used to compare park use. And then our preliminary results are the Google Analytics showed an increase of park use over 150% since the at-home mandate was put in place. And then during our field testing of the instrument and the procedures, it was actually determined that this survey will take about 15 minutes. And then we did determine that linking to a device such as a phone will be optional. Our limitations and delimitations, for those participants that can use a device, that's great, but we're making it optional because it could bias for people that don't have the ability to have those devices. Also, participants may be more motivated to exercise knowing that they're going to be tracked. And then self-reported and fitness tracker data could have the potential for a richer context to how physical activity and the mental health is affecting people during this COVID-19 pandemic, and that will include the child care and the employment factors. Use of phone applications can facilitate the sharing through the and give us the ability to, with the device sharing, compare the self-reported data, and that'll increase validity. We also are submitting for some grants so that we could offer potentially a $50 gift card as an incentive during the pre and post pandemic to help increase our response rates. So the goal is we're trying to gain a better understanding how participants can best report physical activity and stress levels by promoting improved immune systems, reducing stress, and incurring other physical benefits of exercise during this pandemic. The goal is really to provide the public health and healthcare sectors, both with a socially distant design as well as data to better prepare to keep populations active for any future stay-at-home mandates. Thank you. We appreciate you guys listening.
Thank you so much, Chris and Lisa. We now have some time for questions. If you want to chat your questions in the chat box, which is on your screen on the bottom, or if you just want to open up your microphone and ask your question, you are welcome to do that. So I'll open up with the first question, either Carissa or Lisa. I'm wondering, based on previous studies, and I'm sure you've done a literature search on some previous studies, what kind of results do you expect to be able to get from what you're going to be doing?
So, you know, we've never had an experience quite like we are all living right now. So, you know, that's what we've really seen so far. So I think it's going to be interesting to see, you know, we know the response rates from this particular group of panelists tends to be pretty high, over 20%. I think what's going to be interesting and what we are hoping to be able to get some responses with is using this app. So I've seen it done in different ways from some other physical activity studies during COVID-19. And I think we are all kind of struggling with the best way to have folks link their devices. So I think that is one of the really important results of this, is just seeing, okay, do we get response rates from the survey, from the self-report, and then what kind of response rate do we get for people actually linking their devices and participating in the study that way. And then in terms of results, it's hard to say because, you know, it appears in our neighborhoods and we know in our parks that there are more people out there being active, but we just don't know if it's just all of these people are going to the only places they can go, but they would have been at YMCAs and parks, you know, even at their workplace facilities as well.
That's a really good point, yeah. So Dan has a question in the chat box. It's, do you know who is included in the sampling frame population? And also, do you know how the parks created their sampling frame?
Well, I know that they recruited folks for the community pulse, but the short answer is no. I should, you know, I definitely will need that information, and Lisa and I will need that information moving forward so we can speak to any potential bias from that group of people and how it might impact results.
Excellent. Are there any other questions from the audience? And
Lisa, I don't know if you have things to add to either of those questions.
No, you did great.
Okay, why don't we transition to the next speaker. Victoria Langford is an MPH student from Baldwin-Wallace University. And Chris, if you can take down your screen share, then Vicki can put hers up. And she's going to be talking about farm to school best practices in Northeast Ohio, a qualitative research study.
Thank you, Amy.
Victoria, if you could go ahead and introduce yourself, and then I'll start the timer once you start your presentation.
Okay. Hi, I'm Vicki Langford. I'm an MPH student with Baldwin Wallace. I also have over 10 years of experience in healthcare IT as a resource and program manager. Today I'll be sharing my qualitative research study. And let me go ahead and display this full screen. There we go. In this presentation, I will provide a brief overview, including the objectives, methods, and results. Nutritional quality of food in school influence health behaviors and academic performance. Students consume up to 50% of their daily calories at school, and only 1 in 5 students consume the recommended number of fruits and vegetables. Farm to School is a program that was established in 2000 by USDA to increase access and education and consumption of locally grown foods in schools. $5 million is funded annually for assistance to schools through federal grants. And for every $1 spent on locally grown food, it generates $2.16 in the local economy. There are 3 main elements of a Farm to School program: procurement of local foods in school cafeterias, education for students to connect where their food comes from, and hands-on learning in a garden or farm. These elements all benefit child nutrition. Northeast Ohio has several risk factors impacting child nutrition, including hunger, food deserts, and food swamps, and a limited growing season. Farm to School is a proven solution to these concerns. The objective of my study was to explore the best practices of Farm to School programs in Northeast Ohio. Qualitative research was performed with in-depth interviews and leaders of participating and non-participating school districts and a program manager of the Board of Health. All interviews were transcribed verbatim and analyzed for major themes. The next 3 slides represent the interview questions. Participating schools were asked, what challenges were overcome? What feedback has been received from students and parents? And how has the program helped connect students to healthy food choices? Non-participating schools were asked, how does the district promote nutrition and healthy food with students? What benefits are necessary to consider a Farm to School program? And what experiences have students had in the garden or in the farm? And program management was asked, what aspects of the Farm to School program are most compatible with Northeast Ohio? What resources are available to guide and provide assistance? And what success stories can you highlight, and what key dependencies made them successful? This figure represents the geographic location of those interviewed in this study within Northeast Ohio. Analysis of qualitative data uncovered 5 themes and informed best practices to approach schools with knowledgeable resources to influence their likelihood to participate, funding and procurement leverage locally to improve nutritional value, food selection to develop culinary skills in food service staff and healthy choices made by students, interactive education to form self-advocacy and behavior change in students, and engagement of parents and community for wide and sustained value and support. The next 5 slides represent important quotes from each case study analyzed by theme. For participating schools, they said, a desire to provide our students with better quality food and minimize the distance from which our food was coming, with hopes that students would be getting food that is fresher and more nutritious. Non-participating schools said, students learning how to grow things and learning how to cook what they grew would be fantastic. And program management said, Farm to School is probably one of the most flexible programs we can approach a school district with. And how a school district functions, that knowledge is really critical. For funding and procurement, participating schools said, it's really nice because it just comes out of my state provided commodity dollars, so it saves me money. The ordering is easier and it's good to be aware of what is available. Non-participating schools said once you acquire the grant funding, then you have to find the land, find the labor, and how to use it. We don't know how to do a full-scale farming operation, so we're learning as we go. And program management said, how we do local food procurement for school districts, that is the hardest part for schools, but the most impactful. For food selection, participating schools said, more students are eating vegetables because it looks appealing. There's just so much good quality food, a lot less waste, and yes, the taste is so much better. Program management said, so if a school district is already serving an apple, it's not a far reach instead of buying it from Washington to buy it from Ohio. And we've written the bid, and all you have to do is order. For education, participating schools said, we hosted evening activities with students and parents, educating them on buying local and the importance of eating healthy. Non-participating schools said, learning how to implement what we're going to use for our dishes with the food that's grown, operationally, that's tough. And for program management, our hope is that it goes beyond the cafeteria. On the school district side, our challenge is culinary training because some folks don't know how to cut or process if it's not something they're used to using. And lastly, for engagement, participating schools said, students choose more when they know it's local. And program management said, our whole philosophy is that kids should have healthy choices for what they eat, no matter what school district. In conclusion, this figure is a framework of best practices where the inputs and activities drive outputs of schools regularly buying locally grown food, regional partnerships to support adoption and sustainability, and innovation in local farming practices to maximize the growing season, which can all lead to outcomes of improved access to fresh local fruits and vegetables, increased advocacy for students' health and education, and eliminated inequities in quality and variety of nutritional school meals, as well as improved student health and academic performance. Thank you for your attention, and I'd be happy to take any questions.
Thank you so much, Vicki. Does somebody have a question? Okay, so you can either turn on your microphone or you can chat your question in the chat box. And I'll go ahead and start with the first question, I guess. So Vicki, this was a qualitative study. I wonder why you chose a qualitative study as opposed to a quantitative study, and what you thought you got more from doing a qualitative study as opposed to a quantitative study.
I chose a qualitative study because I really wanted an opportunity to meet with schools individually and learn from their experience and their comments. The qualitative insights that I gained, I think, really gave me a sense of their experience and what are some of the barriers that they work through, or what are some of the partnerships that they've unlocked in the region that could help other programs.
And what software did you use for the analysis, or was it manually analyzed?
It was transcribing the interviews. I did attempt using Dragging Anywhere, which is a translation tool. I found it had mixed results, so ultimately I manually transcribed every interview.
Oh, okay. All right. Any other questions?
Yeah, what's this food swamp? I've heard of food desert, but I'm not familiar with the food swamp.
A food swamp is where there's a dense variety of undernutritious foods, high in carbs, right, and fast foods, as opposed to healthy foods like fruits and vegetables.
Interesting. Carissa, did you have a question?
Yes, I was just going to ask what you think, your next steps are. Like Dr. Lee mentioned, do you think that, after doing this qualitative study and better understanding those findings like you mentioned, you might want to do a quantitative study, or what do you think might be next?
Yes, thank you for that question. I think number one, it would be a great opportunity to have some of these potential partnerships that might be untapped in the region so that more schools can explore and plan for an implementation. I think as more schools look to implement, certainly that would, with the right number of time and resources, a quantitative study, I think could be very compelling as well.
Very interesting. Interesting work.
Thank you.
Do we have any other questions from the audience? Okay, Vicki, thank you so much for your presentation. We'll go
Thank you.
ahead and transition to our next speaker, who is going to be Daniel Brooke from the Ohio State University. He's an MD PhD student, and he's going to be talking about the ecological relationship between office-based buprenorphine prescribing and acute hepatitis C virus rate in Ohio in 2018. So Daniel, if you can introduce yourself, and I'll start the timer when you start your presentation. Oh, you're on mute still.
Hi, sorry. As was mentioned, I'm Dan Brooke. I'm an MD PhD student at Ohio State in the Medical Scientist Training Program. I'm in my 5th year, about to enter my 6th. And I'll be presenting on the ecological relationship between acute hepatitis C virus incidence and office-based buprenorphine prescribing in Ohio. A little bit of background. Ohio and nationally, we're experiencing a hepatitis C virus epidemic. Hepatitis C has now overtaken HIV as the deadliest chronic infection, both in the state and nationally. HCV is a costly and debilitating disease. One 90-day treatment for hepatitis C, which has about a 99% cure rate with with the majority of the strains, is between $25,000 and $100,000, depending on your insurance. And for those who aren't treated immediately, over about a 20-year period, some develop cirrhosis and hepatocellular carcinoma, of which the only treatment is a costly liver transplant. HCV is primarily spread through shared injection drug equipment. Many of you probably aware of the opioid epidemic, and a majority of injection drug use is conducted by people with opioid use disorder. Buprenorphine is a medication for opioid use disorder. And in some studies, it and its group of drugs known as opioid agonist therapies, so they work on the opioid receptor, may prevent incident hepatitis C through an indirect mechanism, similarly to how you can think about Nicorette reducing lung cancer by reducing an individual's craving to inject drugs, to inject heroin or other forms of opioids. They reduce their sharing of the injection drug equipment and therefore reduce the spread of hepatitis C. However, buprenorphine can only be prescribed in office-based settings after a special 8-hour training, which gives the provider an X waiver to prescribe buprenorphine in certain number of patients. And counties around the state might be increasing office-based buprenorphine prescribing to slow their individual HCV epidemics. So here's a theoretical model, which in epidemiology we call a directed acyclic graph, to think about this relationship. The exposure here is acute HCV rate in 2015 at the county level. And a physician in 2017 may become aware of their acute HCV rate in their county in 2017 because of the 2-year lag in publishing hepatitis C virus data. The physician might then end up getting the buprenorphine waiver because of the relationship between hepatitis C and opioid use disorder. And then in 2018, that physician might begin to prescribe buprenorphine. Now, when I say physician, this was, again, in 2017. Buprenorphine has since been expanded to other healthcare providers, but before that time was just physicians. So a thing that can confound this relationship or mix up the effects between the exposure acute hepatitis C virus and physicians prescribing buprenorphine is the total hepatitis C virus rate. So in Ohio, we categorize hepatitis C as acute or total, which is acute and chronic hepatitis C. The years 2014 and 2015 I'm using to adjust my model to account for the confounding of that factor. And then another potential confounder that could affect this relationship is the opioid overdose rate from 2010 to 2015. So the overall aim is to describe the ecological relationship between county level acute HCV in 2015 and office-based buprenorphine prescribing in 2018. The hypothesis being that higher HCV rates are associated with a higher office-based buprenorphine prescribing. theoretically, these physicians are seeing the HCV rates in their county and then reacting to it. Data sources for the model, we had buprenorphine prescribing data provided to us by the Ohio Mental Health and Addiction Services. HCV and unintentional drug overdose death data was collected by from the Ohio Department of Health, and county population was gathered from the US Census. The exposure, again, is the acute HCV rate by county in 2015. The outcome is county-level office-based buprenorphine prescribing in 2018. The model that I used was a multivariable negative binomial regression model. And the adjustment set is the acute HCV rate of the prior year, 2014, the total HCV rate in 2014 and 2015, the unintentional drug overdose deaths, 2010 to 2015, the county population size, and then the office-based buprenorphine prescribing capacity. So those who potentially could prescribe buprenorphine, not all of them were. So here in table 1, I have the summary statistics. You can see that from 2014 to 2015, the acute hepatitis C virus rate per 100,000 population increased from the median county level was 0.4 to 0.6. There was a similar increase in the total HCV rate, which again is the acute rate, and the chronic rate. I can go into more specific details if you have questions about that after the presentation, but that increased from 97.4 per 100,000 to 125. And you can see in the county level office-based buprenorphine capacity per 1,000 population at the county level, the median was about 6.78 spots per 1,000 people. And then the actual prescribing of that was a little less at about 5 per 1,000 people. The county level age-adjusted unintentional drug overdose death rate per 100,000 person years was about 17, the median for your counties in Ohio. So here's the model. If we look at the crude incidence rate ratio of the negative binomial regression model, we see that using acute HCV rate per 100,000 population to predict office-based buprenorphine prescribing in 2018, there was about, for every 1 unit increase in the HCV rate per 100,000 population, there was about an 8% increase in the office-based buprenorphine prescribing in 2018. Adjusting for the confounders in our model, we saw an attenuation of that relationship. So a 1 unit increase in acute HCV rate per 100,000 population in 2015 led to about a 4% increase in the office-based buprenorphine prescribing in 2018. And it's to note that this relationship is not statistically significant. So county level acute HCV rate in 2015 does not appear to be meaningfully associated with office-based buprenorphine prescribing in 2018. So what does this mean for the state of Ohio and the health of Ohio? Is that counties may not be sufficiently reacting to the HCV epidemic by increasing office-based buprenorphine prescribing. Again, if we get back to the analogy with tobacco use and lung cancer, theoretically counties with really high lung cancer would be prescribing more Nicorette to reduce cravings to use cigarettes. And theoretically, that's the same relationship with this. Some limitations are we use surveillance data, which has biases in reporting, measurement, and selection. This is ecological data, so a physician does not necessarily, in this model, react to the HCV rate and then prescribe. It's more on the county level. And we have a low sample size with less than 88 counties. And some of the acute HCV data is potentially missing. It's labeled as 0, but we're really unsure if it's actually 0. So in conclusion, increasing acute HCV in 2015 was not meaningfully associated with higher buprenorphine prescribing in 2018 in Ohio. Next steps are to do a sensitivity analysis, assess the preventive relationship between office-based buprenorphine prescribing and HCV. And I'd like to thank my teammates and my funders and you all for being here. So here's the overall conclusion and the model. So you can refer to it if you have any questions.
Thank you so much, Dan. Very interesting. So again, anybody in the audience, you can either open up your microphone for questions or put your question in the chat box. And I guess I will go ahead and start off with the first question. One of your conclusions was that maybe the offices aren't prescribing enough buprenorphine, what other implications do you think there would be for physicians based on your work here?
Well, there's kind of two different ways I think that you can look at this relationship. You can look at it as physicians who have the waiver are not prescribing enough, but you can also look at it as maybe physicians are not even aware of how to prescribe buprenorphine or its effectiveness. And I think even just getting more physicians in the door to get the buprenorphine training, that X-waiver training, can increase people's awareness, reduce stigma around prescribing buprenorphine and treating patients with opioid use disorder. So kind of like with the stages of change, I think maybe this is just one informative step towards like a next step in the stages of change for physicians in Ohio.
Thank you. Does anybody else have any questions? Dan, you did mention a few other steps that you would like to do. Do you think you would be able to do them within your time as a student? Or are these projects for maybe some of the colleagues that you had mentioned?
So I am hoping to do the quantitative bias analysis or the sensitivity analysis. My main concern is about the acute hepatitis C virus rate, and that's a really interesting public health problem, specifically in Ohio because we're a home rule state. So a lot of the counties have quote unquote zero acute hepatitis C in their county. And so it begs the question, do they actually have no acute hepatitis C, or did the counties not have the funding to actually test the patients for acute hepatitis C? So they're just then categorized as like total hepatitis C. And so I want to vary that number to see where I can get it to actually change the model relationship to make it a significant relationship, and see if these numbers are wrong, what is too wrong to make this relationship in the direction we think it should be, or think we hypothesized it would be. And then the other next step is the preventive relationship between buprenorphine prescribing and HCV. And that's the overarching theme of my dissertation. So hopefully within the next year or two, I'll be able to answer some of those questions in three different aims.
So what are you doing for your dissertation then?
So essentially, I'm trying to flip this relationship. So this model, flip this relationship on its head. The idea being that I'm looking at actually, if physicians are prescribing, say, buprenorphine in 2010, does that reduce the acute HCV rate in 2015? So the problem is that acute HCV data is lagged to the point where I can't actually study the preventive effect of this for several years because of the lag in publishing the data and the theoretical lag in how this would act preventatively. So it could take a year or 2 years before a physician prescribing buprenorphine to an individual or population actually reduces the hepatitis C in that population.
Or as you had said before, having a number of a number of physicians actually trained to be able to prescribe. So
yeah.
Okay. Again, for the audience, any questions? Feel welcome to open up your microphone or put a question in the chat box. All right, one more question for you, Dan. When you graduate with your MD and MPH and your PhD, what residency do you hope to do, and what do you plan to do for your future career?
So right now I'm thinking of joining or applying to PSTPs, the Physician Scientist Training Programs, which are an internal medicine fast track program. I'm looking at several of those, probably infectious disease. I don't know. I still have like 2 years left of clinical training to get my feet wet in all the different specialties to see if that's the best fit for me. But as of now, I love studying infectious disease epidemiology. I love all the ways that it can integrate all the other specialties within internal medicine in public health. And so I think that's where I'm leaning towards, infectious disease specialty.
Excellent. And I think your career is off to a great start with some of this kind of research that you're providing, and some of the critical thinking and the questions that you're providing as well. Thank you. All right, we're now going to transition to our last speaker. Abe Malalo is a faculty member. So we've had faculty and 2 students, an MPH student and an MD PhD student. And now we are back to a faculty at Baldwin Wallace University, and he's going to be talking about the application of machine learning models and predicting the hot spots of age-adjusted mortality rates of lower respiratory infection in the USA. So Dr. Malalo, welcome. And I'm going to ask you to share your own PowerPoint. There's an icon at the bottom of the screen. And if you could share your PowerPoint. And we have the timer, as you've seen. And the timer is going to give you 6 minutes of green, 1 minute of yellow, and then it'll ring for the,
I think, thank you very much, Amy. I think my presentation is going to be more than 6 minutes, a little bit, a few minutes more than that.
Okay.
Probably less than 10 minutes.
Okay. If you could introduce yourself, and then you can go ahead and start.
Thank you very much, Amy. So good morning, everyone. I'm Abe Malalo, Assistant Professor of Public Health from Baldwin Wallace University. I hope you had a wonderful day so far. So in this presentation, I'm going to briefly talk about our research project on mortality rate of lower respiratory diseases using machine learning techniques to predict the location of hotspots in the United States. So let's start with some basics. Lower respiratory infections are bacterial or viral infections that occur below the larynx. So in this picture, which shows respiratory system of a human, here is larynx, and below the larynx, we can see trachea, bronchi, lungs, which are related to the lower respiratory system. And above larynx is upper respiratory system, which is not the subject of our presentation. So lower respiratory infections consist of a range of lower respiratory diseases, but the main diseases are pneumonia and also bronchitis. And it should be noted that almost 90% of lower respiratory deaths attributed to the pneumonia. And if an individual is diagnosed with lower respiratory, the main symptoms that he or she may have are wheezing, chest pain, coughing, fever, and also fatigue. So according to the World Health Organization, WHO, in the year 2016, almost 2.5 million deaths were reported because of the lower respiratory infection across the world. And the disease is a leading cause of deaths among young children and age group less than 5 years old, and is the number 6 leading cause of deaths for all ages. And in the United States, which is our study region, our study area, every year it poses a huge socioeconomic burden to the healthcare system. Almost $9.5 billion a year is spent for treatment and prevention of the disease. It's also the most common cause of hospital admission for adults in this country. So this map shows a spatial or geographic distribution of LRI mortality worldwide for all ages. As you can see, mortality is highest in Central Africa, and in the United States, it's between 25 and 49 cases per 100,000. And among children less than 5 years old, mortality rate is highest in the Central Africa. In the United States, that's very low mortality rate. It's between 0 and 4 cases per 100,000. But among elderly people, it's more serious. People with age greater than 70. In the United States, it's between 120, 250 cases per year, per 100,000 in the United States. So there are very few studies that focus on the geographic aspects of the disease, of the lower respiratory infection. And to our knowledge, nationwide geographic distribution and modeling of the lower respiratory infection has never been investigated. So to control confounding effects, we obtained age-adjusted mortality rate of lower respiratory from JAMA for 8 years, starting 1980, 85, and all the way up to 2014. The data were available at the county level across the United States, and we assume that all reported cases represent the status of the disease in the United States. And also administrative boundaries of counties obtained from Tiger Line, and we joined the mortality rate to the corresponding location in ArcGIS for each year separately. And for geographic modeling, we collected several explanatory variables such as climate data, minimum maximum temperature, total precipitation, fine particulate matter, PM2.5 to represent air pollution, sunlight. So these data were obtained from the CDC Wonder. Smoking prevalence for male and female obtained from a published paper in Population Health Metrics. And digital elevation model was used to extract elevation and also maximum slope for each county. And the data were obtained from the USGS and prepared in ArcGIS environment. And finally, a broad range of socioeconomic variables such as proportion of white and black population, median household income, poverty, and so on were used as explanatory variable, and the data were obtained from the American Fact Finder. So in this research, we are interested in finding answers for this question. So which counties persistently identified as hotspots of LRI from 1980 to 2014, almost 35 years? Which factors could explain presence or absence of the LRI hotspots? And finally, which machine learning techniques or machine learning algorithm had highest accuracy in predicting the location of the hotspot? So first, we use global clustering techniques such as global Moran's I and general G to statistically examine the type of distribution. Is there any clustering or not? And then if there is clustering, we use local indicator spatial autocorrelation or LISA to identify the location of hotspot. And finally, 5 different machine learning classifiers, logistic regression, random forest, gradient boosting, and SVM, were used to predict the location of the hotspot. So the results, global Moran's I showed that for each year the distribution was clustered, statistically significant. Then we plotted the Z-score, which shows the intensity of clustering. And as you can see, the distribution is becoming more clustered and random over time. And the same for general G, another clustering technique. And as you can see, the Z-score after we plot for each year, it was significant, clustered, and the Z-score increased. And it shows that the distribution becomes more focused and focused. So, but the question is, where are the hotspots of LRI? So for this purpose, we used local indicator spatial autocorrelation for each year. And here is the result of LRI, of the LISA, local indicator spatial autocorrelation. You can see as we move from 1980, 1985 on all the way up to 2014, the distribution of hotspot or red counties becomes more focused or less dispersed, and which confirms the result of the global Moran's I and general G. And also there was a shift in the distribution of hotspot. If you look at the distribution, so it was first in the western part of the US, but as we move forward, the distribution moves to the southeastern part of the eastern and southeastern part of the United States. So in the next step, we intersected the location of the hotspot to identify which counties were persistently identified as hotspot. And we ended up with only 77 counties. And it's interesting that 81% of the hotspots only occurred in these 3 counties in Georgia, Kentucky, Virginia. And this suggests that these areas are persistently identified as hotspot of LRI and require closer attention. During the 35 years, they are still hotspot of the lower respiratory infection. And Here is the result of accuracy assessment. So because of the data, we were imbalanced. We use the precision recall curve for all models. And as you can see, this one, gradient boosting, at the highest area under the precision recall curve. And we consider this as the best classifier to identify the location of the hotspot. And so all of the models had a relatively high accuracy in predicting the location of the hotspot, but decision trees, gradient boosting, and also random forests obtained the highest accuracy F1 score, precision recall curve, area under the precision recall curve, and with 92% overall accuracy on the independent dataset or test dataset. So in summary, geographic distribution of, I forgot something. Yeah, so the GBT model indicated that spring minimum temperature, there is a positive association between the spring minimum temperature, winter precipitation, and median household income in locating the hotspot. So in summary, the geographic distribution of LRI mortality in US was clustered and is becoming more focused. Hotspots shift from west to southeast part. And some counties were persistently identified as hotspot, indicating that public health policymakers should pay closer attention to these areas. And decision trees, random forest, and gradient boosting had the highest accuracy in locating the hotspot. And but it should be noted that the findings are only applicable at the county level. So we can't make conclusion at the sub-county or individual level. However, for targeted interventions, it is highly recommended to perform analysis at the sub-county level, such as zip codes or census tract. Thank you very much.
Thank you, Dr. Malalo, for your presentation. At this time, again, the chat box is open in case you would like to enter in your question, or you can just open up your microphone and ask any questions. So I have a question. You said that it seemed like a lot of the hotspots seem to be clustered around the southeast area of the United States. Can you suggest a reason why?
Oh, that's a very hard question, honestly. So we can't say that. We can't say for sure what is the reason there is a shift in the distribution, but the variable that could explain the location of the hotspot for the year 2014 were temperature, precipitation, and income with the very high accuracy. So, but the main reason probably is not, we don't know that.
Yeah, sometimes you may try to think of some possible reasons. So I was just wondering if you've thought of potential reasons for that.
I don't know that.
Okay. Oh, yes, go ahead, Dan.
I can't remember exactly what you controlled for, but did you control for tobacco sales as a part of the county's outputs? Like if tobacco was grown in those counties?
No, smoking was an explanatory variable, not a, it didn't control for, consider it as a confounder, no. It's an explanatory.
Because I was really thinking about the map looks very similar to where tobacco is grown in the United States historically and currently.
That's a great thing. Thank you very much.
Yeah.
Look at the spatial distribution.
When you're smoking, you're reducing your immune system and put yourself more at risk for a low respiratory infection.
Is it the distribution is similar to the geographic distribution of the tobacco? The distribution of clusters?
So the per capita like sales of tobacco as of total market output, I think is what the map is in those counties. Like if tobacco is the largest product of the county, then it correlates very similar to the map.
Thank you so much. Thanks.
Carissa, did you have a question?
I did. That's very interesting. And I'm wondering, like Dr. Lee was saying, so is, that cluster that you found, is that part of your next steps and your, with your research that you are going to look into?
Sorry, I didn't hear that what you said. Sorry.
Sure. So like Dr. Lee was saying, when you found that cluster in one specific region, is that something that you're going to investigate further in future research?
Yeah, so clustering kind of is the first step for generating the hypothesis. So what is going on here? And but in the future research, we're going to not looking at the variables that can explain the cluster because it's just 1 and 0 is a binary classification. In the future research, we're going to work on the predicting the actual rates using the machine learning techniques. So not the cluster 0 or 1.
Okay, that will be very interesting as well.
Thank you very much.
Any other questions for Dr. Malalo? If not, I want to, at this time, thank all of our presenters for our first ever virtual public health academic forum. And I thought all of the presentations were fabulous. Thank you so much. And before you all leave, I would like to make sure that you know about our poster presentation. It's a virtual poster presentation going on right now at PH or Public Health, phacademicforum.edublogs.org. And you can see our posters going on right now. They're posted from the 22nd to the 29th. And you can click on any one of these posters and you can click on the poster and download it so that you can see it pretty well. And you can also leave a reply so that you can either ask questions or maybe provide a resource for that student or a comment or a suggestion for the student. And we are asking them to check back maybe 3 times or so during the week, and they would be able to answer your questions. So this is an interactive virtual poster forum, and we hope you join our 12 fabulous poster presentations as well. So at this time, I'd like to thank everybody for participating and bid you farewell and have a good rest of the week. Thank you so much. Oh, by the way, these presentations are going to be posted on this Public Health Academic Forums.edublog website as well as the videos. And it looks like I have a chat. Let me just see what, okay. So thank you again so much, and we hope you join us back on our webpage. Bye-bye.